Okay, good morning. Today I'm going to present on a comprehensive update of prolotherapy in management of knee osteoarthritis. So this journal is being published in year 2022, early January this year. So it's by this Alex Tang and other researchers from United States. So first they was talking about this introduction, formally introduced by this George Hackett, which is the US General Surgeon in 1950. So what is prolotherapy? Is a regenerative therapy whereby they inject the irritants into the periarticular or intra-articular to stimulate the cytokine and growth factor to leading to regeneration of the damaged ligaments and tendon. So the journal focuses on current treatment options of osteoarthritis, prolotherapy, and emerging evidence on use of prolotherapy for treatment of knee osteoarthritis. So there's indication for prolotherapy. So the first one is knee osteoarthritis with chronic pain and radiographic findings of Kellgren-Lawrence from grade 2 to grade 4. The second one is prolonged pain including enthesopathy, tendinosis, and also ACL laxity. Third one, those failed with physical therapy, surgery, or intolerance to NSAIDs, steroids, or opiates. So the last one is chronic ligament or tendon pain due to sprain and strains. So the techniques, usually knee will be examined first and the tender location will be marked. So prior to give the injected, so you need to give lidocaine 0.1 to 0.5%. So they use extra-articular injection in the site of tenderness using a peppering technique. So it will cause more inflammation and cause regenerative process. So in this case, they preferred inframedial and infralateral intra-articular approach compared to suprapatellar. So after getting the injection, advise the patient to can take acetaminophen or any narcotics for pain, but no NSAIDs. To take rest at least 2 to 3 days, and the injection intervals is from space between 4 to 6 weeks apart, with individuals averaging between 4 to 6 treatments. And then if after 3 prolotherapy sessions, if no improvement, then for alternative interventions. So there's a few types of injected that we can give. The first one is dextrose. So we have 10%, 12.5%, 16.5%, 20%, and 25%. So diluted with local anesthesia in 1:1, 1:2, 1:3, 1:4, or 2:5. So the study shows that D25 is most appropriate in treatment of intra-articular knee injections. So have sodium morphate 5%, which composed of 2.2% of benzyl alcohol and sodium salts of cod liver oil. And this DPG consists of dextrose, phenol, and glycerin. So dextrose of 25%, phenol of 2.5%, and glycerin 25%. So dilute in local anesthesia 1:1, 1:2, or 2:3 concentration before the injection. So what are the contraindications? Those who are having allergies to anesthetic or proliferative solutions, acute arthritis, bursitis, tendinitis, gout, complete rupture of tendon, ligament, or rheumatoid arthritis. Those having active infection, cancer, immunocompromised patients. And relative contraindication, usually regular use of NSAIDs and steroids, contracting the body inflammatory process. Then the long-term use of narcotics usually will lower the body immune response. So side effect wise, the most common one is soreness and swelling at the site of injection. So the less common one is the infection. So the additional risk that you have to aware of is bruising, headaches, allergic reactions, temporary numbness, and nerve irritation. So current treatment options for knee osteoarthritis. So the first one, exercise and weight loss. So study shows that 7 to 10% weight reduction sufficient for pain relief. The second one is massage therapy and biomechanical interventions like braces and walking canes. So the third one will be pharmacological treatments. We have topical, oral and injections. So the topical capsaicin, ACR prefers more to use topical capsaicin compared to topical NSAIDs, and patients prefer to use oral NSAIDs compared to topical. Oral wise is NSAIDs and tramadol. Injections we have steroids, hyaluronic acid, PRP, prolotherapy and stem cells. So the injection for steroids it's still controversial because they said it will increase loss of cartilage volume. So the last one will be surgical interventions. So the mechanism of action of prolotherapy is they will injectates will initiate the local inflammatory response, which trigger the healing cascade. So the release of cytokines and growth factors which promotes the proliferation of the fibroblasts and will deposit more collagens. So it will strengthen the joint and also will reduce the pain. So the mechanism of action for these three hypertonic dextrose, the first one, hypertonic dextrose, will rupture the local cells via the osmotic gradient. So other alternatives is like they said activation of inhibitory of glycine receptor will cause hyperpolarization and reduction on the nociceptive transmission. That is for the hypertonic dextrose. For DPG, it will initiate the local cellular irritation. And for the last one, sodium morphate draws inflammatory mediators that leads to scarring of pathologic neovasculature. So there is a clinical effectiveness. Actually, roughly about 5 studies are included. The first one is this Farpor and Faridoni. They did a randomized clinical trial studies for this using the outcome measurements, OKS, Oxford Knee Scale, WOMAC, which is the Western Ontario McMaster's Osteoarthritis Index. They have the scale of pain, stiffness and function. So the worse, the greater the score is it, the worse the pain lah. And VS, visual analog scale. So from this study, they came out that they did a study on two groups, which is using a dextrose prolotherapy using an intra and peri-articular. So they said peri-articular easily to be given than intra-articular. So that is for the Farpor and Faridoni. The second one is the Rahimzadeh. Rahimzadeh used randomized clinical trial. They used outcome measurement as WOMAC also. So they did a study on both this group injection via PRP and also DPT, and they came out with a conclusion that both also can be used to reduce the pain and quality of life. And then the third one is Pisagi. Used a randomized clinical trial, used WOMAC and VAS. So this they did a research on these two groups, which three groups, which is they divided into ACS, PRP and DPT. So they came up with that the ACS is, can be potentially used as alternative to PRP and also DPT. So this guy did in 2020. So then Reza Soltani did a randomized clinical trial also. Outcome measurement is VAS, visual analog score pain, and then the secondary one is the knee osteoarthritis outcome scale. So they did a study on these 4 groups, which is the physical therapy, Botox and HA and also dextrose. So they came out with the conclusion that is the Botox, dextrose and also physical exercise can be used and will be effective to control pain compared to physical therapy alone. So that is the results Tani. And the last one is SID did a randomized clinical trial as well. So with outcome measurement, the primary as a WOMAC and the secondary as a WOMAC as they differentiate the function and stiffness and VAS and also with physical function and with Eurocall 5D score. Eurocall 5D score is to measure on the quality of life actually lah. So they differentiated between dextrose and also normal saline lah, the study on dextrose and normal saline. So came up with conclusion that compared to normal saline, dextrose has improved measurement of pain, function and quality of life. So in conclusion, prolotherapy is safe and effective based on the RCTs done, and improvement in radiographic outcomes, pain scores and quality of life. So the things that to look more in the future is need to be further standardization of method of administering the peri-articular prolotherapy if used in combination with intra-articular prolotherapy. The second one, need to be further studies comparing other forms of injected, example like PRP, ozone and also erythropoietin. The last one, need further studies with extended follow-up periods evaluating the long-term effects of prolotherapy. That's all.